Okay, so when I say the word diabetes, what's the first thing that pops into your head? I'm guessing it's something about blood sugar, right? Insulin, maybe diet? But what if I told you there's another, much rarer condition that shares the name but has almost nothing to do with sugar at all? Let's dive into this fascinating medical mix-up.
So let's just start with a question to kind of reset everything you think you know. What if the core problem of a type of diabetes wasn't about managing sugar, but was all about managing water? Well, that's exactly what we're talking about with diabetes insipidus.
All right, let's break this down. It's super clear when you see it side by side. On one hand, you've got diabetes mellitus. That's the one we're all familiar with. It's all about sugar control, and the hormone in charge is insulin. But then you have diabetes insipidus. The game is completely different. Its core issue, water balance. And the key hormone, something called ADH. They might share a symptom, like frequent urination, but the reason why is worlds apart.
So, to really get a handle on diabetes insipidus, we need to meet the body's chief water manager. And this has nothing to do with insulin. It's all about a hormone called ADH.
So what is ADH? Well, the name kind of gives it away. Anti-diuretic hormone. Think about it. A diuretic is something that makes you pee more, right? So anti-diuretic does the exact opposite. It's a chemical messenger from your brain with one simple job: to tell your kidneys, hey, hang on to that water. We need it.
In a perfect world, here's how this system works. It's actually a really elegant little feedback loop. Step 1, your brain senses, we're getting a little low on water. Step 2, it tells the pituitary gland, okay, release the ADH. And then step 3, that ADH travels down to your kidneys and gives the order to pull water back into the body, producing less urine. Simple, right?
But what happens if that signal gets cut? What if the message from the brain never, ever reaches the kidneys? Well, you end up with a system where the tap is just always on, full blast, and it refuses to turn off.
And that leads to the two major hallmark symptoms of this condition. First, you've got polyuria. That's the fancy medical term for just a massive amount of urination. I mean, since the kidneys aren't holding on to water, it just flows right through you. And that, of course, leads directly to symptom number 2, polydipsia. This isn't just being thirsty. This is an extreme, absolutely relentless thirst, because your body is just screaming to replace all the fluid it's constantly losing.
You can see how this becomes a really vicious cycle, right? The body can't hold water, so the urine becomes dangerously dilute. This means you're in a constant state of dehydration, which then triggers this totally unquenchable thirst. It's just an exhausting, all-consuming loop to be trapped in.
And if this goes unmanaged, the consequences are really, really serious. We're talking about severe dehydration, obviously, but also something called high serum osmolality. That's just a technical way of saying your blood gets way too concentrated with salts because there's not enough water to balance things out. And that is a very dangerous state for your body to be in.
Okay, so we get the what, but now for the why. Why does this happen? Where is this communication breakdown between the brain and the kidneys actually coming from?
Well, we're going to focus on one specific type called neurogenic DI. And the name itself gives us a huge clue. Neuro points us right to the nervous system. This means the problem starts in the brain. For one reason or another, the brain just isn't making, transporting, or releasing enough of that crucial ADH.
And this isn't usually something you're born with. It's almost always triggered by some kind of physical event that messes with those delicate structures in the brain. We're talking about things like a serious head injury, a brain tumor, a nasty infection in the central nervous system, or even complications from brain or pituitary surgery. Okay, but here's the good news. Once you really understand the root of the problem, that it's just a missing signal, the solution becomes surprisingly straightforward. It's all about finding a way to restore that lost communication.
And really, the solution is just beautifully simple and logical. If the body isn't making the ADH hormone, well, you just give it back. You replace the messenger that's gone missing. Now, there are a couple of options for doing this. The older treatment is something called vasopressin. It works, but it comes with a pretty significant side effect. It constricts your blood vessels, which isn't great. That's why today, the go-to therapy is a drug called desmopressin, or DDAVP for short. It's basically a synthetic version of ADH that does the water-saving job perfectly without that blood vessel squeezing effect. It's just a much smarter, safer way to go.
But here's the thing. Treatment is not a set-it-and-forget-it kind of situation. It's a really delicate balancing act. Doctors have to keep a super close eye on a few key things: how much urine the patient is producing, the concentration of that urine, that's called specific gravity, and most importantly, the level of sodium in their blood.
And there's a huge reason why that monitoring is so critical. If you give a patient too much of the medication, their body can actually start holding on to too much water. And when that happens, it can dilute the sodium in their blood down to dangerously low levels. That condition is called hyponatremia, and trust me, it comes with its own whole set of serious problems.
And that brings us right back to where we started. So, the next time you hear someone say diabetes, just remember, it's not always a story about sugar. Sometimes, as we've seen with diabetes insipidus, it's a story about water, a story about a missing signal and a delicate balance that, thankfully, modern medicine knows how to restore.
It really makes you think, though, doesn't it? How one word can describe two completely different conditions. And it leaves me with one final question for you. What other medical terms do we throw around every day, thinking we know exactly what they mean, when there might be a whole other, fascinating story hiding just beneath the surface?